Okay, next we're going to move on to our upper cervical assessment. Again, this is just a more specific assessment of the spine. We've already gone through our mid and lower cervical spine, so we certainly should go through mid and lower cervical as a general screen initially, where we're looking at our active, our repeated, our passive, our single segmental testing. In the event that we screen the mid and lower cervical spine and either we found nothing and we suspect upper cervical dysfunction, or we found mid and lower cervical dysfunction, but we also suspect that the patient has upper cervical dysfunction, we're going to move on to a little bit more detailed examination. Just something to keep in mind, your repeated motions of your mid and lower cervical, they affect your upper cervical spine. So as we had Mark doing protraction and retraction, we were affecting the upper cervical segments from a repeated motion standpoint. So when we do our upper cervical exam, we don't go through repeated motions again. We're assuming we've already cleared those through our mid and lower cervical exam. Some reasons that we'll look at the upper cervical spine would be Mark's complaining of headaches. So if he's complaining of headaches, particularly anything radiating into the frontal, temporal regions or vertex of the head, would generally suspect, or even retroorbital pain would all suggest upper cervical symptoms in nature. We would certainly want to rule out non-mechanical sources of cervical pain, certainly more sinister pathology. We'd also want to, again, rule out other types of headache generators such as migraine or tension type as well. So in the event that we've cleared those components from a possible diagnostic list, then we would move on to our mechanical exam of the cervical spine. In terms of the examination of the upper cervical spine, we're just going to do our active motion, range of motion measures a little bit more specifically. So the first one that we'll have Mark do is we're going to look at upper cervical flexion and extension. To do that, what I'm going to have him do is to rotate towards me, which generally is going to lock out C1, C2. So when we're looking at upper cervical flexion, we're looking at occiput on C1. And we're going to ask him to perform a nodding motion. So he's going to flex the chin and then extend and then flex. And generally we're moving through an axis through the ear as we assess flexion and extension in this position. There's generally 10 to 15 degrees of flexion, about 20 degrees of extension as we're looking at occiput C1. So we rotate the head, we have the patient flex and extend the head, imagining an axis through the ear. For upper cervical side bending, so generally this is occiput on C1, we're only going to see about 5 degrees of side bending. To do this maneuver, what we're going to have Mark do is tip the head side to side, imagining an axis right through the nose. So we're going to have him gently side bend the head to the right and the left, and we're just generally getting a look at the amount of motion he has, and this is generally occiput on C1. He's doing this pretty well. Sometimes you'll have to guide the patient, so you may have to guide them so that you're not looking at side bending through the entire cervical spine. So we want to get more of a segmental side bend to either side, and we should see roughly 5 degrees to either side. The next assessment we can look at, and this would be one of the primary motions that would alert us to perhaps upper cervical dysfunction besides our pain pattern, would be rotation. For rotation, we're looking at most of our motion at C1, C2. Almost 50% of our rotation that occurs to either side of the spine occurs at C1, C2. To look at this motion in isolation, what we have Mark do is to flex his head, chin down towards his chest, and then from here we're going to have him rotate to the right and to the left. And from this position, he should have 45 to 50 degrees, which he's pretty darn close to. See, about 40 we're looking at to either side. So that would be our assessment of active upper cervical motion. So we're looking at this for the same reasons. We're looking at a gross idea of his range of motion, or trying to get a gross idea of his range of motion. We're looking at his willingness to move. We're getting an idea of the irritability of the condition, and certainly we're taking note if any one of those motions provokes his headache-like symptoms or upper cervical pain. So that would be our active. After we're done with our active, again, I said we don't do repeated in the upper cervical. We generally save our repeated for the mid and lower cervical. Before we get into our passive assessment, because it is a little bit more specific, it also should be noted that in his history, if there's any suspicion, again, of trauma, of ligamentous instability, vertebral artery insufficiency, we should have screened for those conditions prior to performing these techniques. So our passive testing, we're going to have Mark lay on his back. And we're going to take a look at a couple of different motions. So first we'll look at flexion as we did actively. To do flexion, this looks very similar to our muscle balance assessment that we did for the suboccipital musculature. We're just using it in a different capacity now. So I'm going to grasp underneath Mark's occiput. I'm going to place my hand on his forehead, and I'm creating a force couple. So as I'm pulling in an anterior superior direction with my right arm, I'm pushing in a caudal in posterior direction with my left hand. So the motion, again, for flexion, the upper cervical is through the ear, and I'm going to perform this type of maneuver. I'm assessing his end feel, which should be capsular, And then the quality and amount of motion he has, the sequence of pain and limitation. But again, generally, passive testing is done to assess the joint. If I want to isolate one OA joint versus the other, what I can do is rotate the head. If I want to apply more stress to his left OA, I can rotate his head approximately 30 degrees to the left, and then perform the same maneuver from this position, which is going to give me a little better idea of motion in his left OA, which is a little bit more restricted on Mark. Then I can switch and assess the right side. Again, rotate 20, 30 degrees, and then perform the same maneuver from this position. He's got definitely has more motion in his right OA than his left OA articulation. So that would be flexion. For side bending, we call this an occipital rock is in essence what we're going to be doing. Similar force couple to what I did for flexion and extension, but I'm just going to change his head position. So to lock out the mid and upper cervical up to C1, C2, I'm going to take Mark's head, I'm going to grasp his head on either side with my MCPs over his zygomatic arch. I'm going to rotate his head to the side so that my bottom hand is flush against the table, my top hand, again, is my fingers are pointing down towards his feet, and then I'm going to perform this same force couple. My top hand is pushing in an inferior and a posterior direction. My bottom hand is pulling in a superior anterior direction. So this, in essence, what I'm doing is I am gapping his left OA joint. So the joint that's the side that's closest to the table, that's the joint that you're going to be applying stress to. To check his other side, I'm going to rotate his head back to the other side. And this can be pretty aggressive. Remember, we're only looking at 5 degrees. If you see the patient's head coming off the table, you're obviously not isolating it to the upper cervical. Your bottom hand should maintain contact with the table just like the upper cervical flexion. But be careful again when you're doing this because it does apply a fair amount of stress to the occipital occiput C1. Other hand on top, same force couple. Bottom hand is pulling in a superior anterior direction and top hand is pushing in an inferior and posterior direction. And we're just looking again, does he have roughly 5 degrees? What's our end feel? What effect does it have on his symptoms? Okay. So in essence, this is passive testing. It's also single segmental testing. Because we're blocking out motion to lower segments, it really is isolating motion to one level. The last passive motion I'm going to check on Mark is rotation. To do rotation, I'm going to raise the table up a little bit. He can stay in a supine position. And what I'm going to have Mark do is to slide down towards me. Okay. And from this position, what I'm going to do is I'm going to rest his head against my abdomen. What I'm doing is I'm flexing his cervical spine so that I'm blocking out motion in the mid and lower cervical spine. I'm going to place my hands over his zygomatic arch. And from here, what I'm going to do is to assess right rotation. I'm going to rotate him to the right and assess the end feel. And then I'm going to do the same thing in rotating him to the left. And the idea again is to block out motion in the mid and lower cervical and then to get an isolated motion at occiput and C1. If I lose that degree of flexion, his range of motion is going to improve dramatically because I've lost that blocking out. This is sometimes called a soft tissue or muscle lock because what's locking out the mid and lower cervical spine is tissue in the ligamentous and muscular structures in the cervical spine. So flex him up, place his head against your abdomen, and then while maintaining flexion, rotate to either side, assessing range of motion and the quality of the motion. Another way to do that is if I have him slide towards his feet, as opposed to locking out his mid and lower cervical spine by flexing the spine, what I can do is we call it a bony lock. So instead of using soft tissue, some therapists will choose this procedure. And to do a bony lock, again, we're doing this to assess upper cervical rotation. What I'm going to do is close down all the facets on one side. To do that, what I'm going to do is to side bend Mark's head to one side, keeping him in neutral. I'm going to push the shoulder down on the side that I'm side bending him to so I can side bend him a little bit further. So what I've done now is I've closed down all the facets on his right side. And what I'm doing is leaving motion really left to occiput or C1, C2. So from this position I can assess his rotation. Here, if I maintain my side bending force, I can rotate him back and I can get a pretty good idea of his upper cervical rotation. I can do the same thing to the other side, is I can side bend him, push the shoulder down, take him to end range, and then from here, again, as I maintain side bending, is rotate him back, and I can get a pretty good idea of his upper cervical rotation to either side. I find it's a little bit more comfortable for the patient if you do the flexion maneuver, but you certainly could use either technique with your patient based on their tolerance. So that would be our active and our passive assessment of the upper cervical spine. Next would be our resisted testing, so if you could have a seat up for us, Mark. And for our resisted testing, very similar to what we did for the upper or for the mid and lower cervical. Again, understanding it's very hard to isolate our forces to one particular level of the cervical spine. So to do a quick check of some of the musculature around the neck, what we generally do is put the joint on a little bit of slack. If I want to check his flexors, I tip his head back a little bit. And from here, my cue is don't let me move you. And I can check his cervical flexors. I can flex Mark's head forward a little bit. Don't let me move you. And I can check his extensors. I can check his side benders by side bending him away from me to gap the joints on the right side. And again, my cue is don't let me move you. I can do the same thing to the opposite side. Tip his head a little bit to the side. Don't let me move you. And same thing for rotation, is rotate Mark's face to the side a little bit. And again, don't let me move you. And same thing to the opposite side. So rotate to your right a little bit. Stabilize and don't let me move you. So that would be a quick screen of the cervical, upper cervical musculature. Probably a more valid assessment from a clinical standpoint would be to look at deep cervical flexor strength, which we've talked about before. You can do that a few ways. You could do that with the blood pressure cuff, starting with 20 degrees or millimeters of mercury and looking to see if the patient can increase his holding capacity by 2 millimeter increments up to 28, holding each repetition for 10 seconds without substitution. We could also use that quick screen that we demonstrated before, which hasn't been validated, but clinically you may find some use for it, is if we have Mark lay on his back. And to do this procedure, all we're going to do again is support Mark's head, have him retract his chin, and then my cue to Mark is from this position, I'm going to take my hands out from underneath your head. I want you to hold that position, and we look to see if Mark is able to hold that position for 30 seconds. 30 seconds, again, is a fairly long amount of time, even for your typical patient. So what we would look for is if he failed before that would be as if he started to shake, as if the muscles were failing, if his head drops, or if we see his chin protract, where he's recruiting his SCM or scalenes would indicate that perhaps, again, he has weakness, and we can document the amount of time he can hold that contraction before we see compensation. So that would be our resisted testing. If you want to have a seat up, from a neurologic standpoint, we certainly could do a quick check of some of the dermatomes, but we don't have a lot of dermatomes to look at in the cervical spine. There really is no C1 dermatome represented in the cervical spine, so from an assessment standpoint, we could do C2, which would generally be in the temporal region, so we could assess bilaterally. So if he had entrapment of the nerve or nerve dysfunction at C2, he may complain of sensory changes from one side to the other. C3 is generally the lateral border of the neck, so we could check sensation from that standpoint as well. And from a myotomal standpoint, again, we've generally looked at his strength going through our manual muscle testing or resisted testing. The last thing that you might mention to take a look at would be your neuromeningeal tests or your upper limb tension tests. Again, those certainly can be related to headache-like symptoms, so taking a look at LVs, taking a look at your median, radian, ulnar nerve tests to see if those particular tests reproduce the patient's headache symptoms would be of some benefit as well in the clinical setting.